Good afternoon, everybody, and welcome to the first rollout meeting of the Stroke Action Plan Europe, a joint initiative of the European Stroke Organization and Stroke Alliance for Europe.
Some of us who didn't play with support from the bench.
As mentioned in September, this is a very important moment and event for which ESO and SAFE have been working for more than 2 years. We have more than 90 representatives from about 50 countries on this call, with at least 2 representatives from each scientific organization and at least 1 representative from the respective national patient organization. A truly unique moment. So once again, a warm welcome. Stroke remains one of the leading causes of death and disability in Europe, and projections show that with a business as usual approach, the burden of stroke will not decrease in the next decade or beyond. And this really is why ESO, in collaboration with SAFE, following earlier meetings in Helsingborg 3 years ago, decided to come together to review the scientific evidence and state of current services, to identify priorities for research and development, and to set targets for the development of stroke care for the decade to follow. The initiating meeting for the current process was held in March 2018 in Munich. Since then, the organizers have been preparing towards this. As Hanne Christensen and Aline Wilkie and also Francesca Romana will illustrate in a minute, there are crucial gaps in stroke care that do require a focused and coordinated effort, regardless of geographical region and also regardless of the level of care. What ESO and SAFE want to achieve with the Stroke Action Plan Europe is to set up a framework that assists countries in improving stroke care and that enables us to closely work with you, the national stroke societies and patient organizations, to achieve our aim, which is to improve stroke care across Europe. We will need your input and collaboration and would hope you agree this is an important aim that can best be achieved by a structured process. Today's meeting will be followed by 2 additional roll-out meetings, one in December and another one in January. Hanne and colleagues will provide you with the details. So thank you to the organizers, Hanne, Aline, and Francesca. And thank you for joining this important initiative. I do hope to see you soon in person. Thank you.
Thank you, Martin, for your introduction. We will continue right away. After, I just want to welcome everybody. We're so grateful that you want to participate in these meetings to support this very, very important process. The first speaker will be Valeria Carso, who will talk on how to collaborate with political stakeholders to improve stroke care. Thank you, Valeria, for joining with this presentation with a very short delay.
Sorry, I'm trying to share my screen. Sorry. The reason I was asked to talk about this is, you know, that for me, the collaboration with other stakeholders, it's based on a mantra that a teacher, one of my former teachers told me, to share what you are doing in your hospital together with all the world outside. And you cannot be the best scientist, and you know how important it is to share what you are doing without involving others. And this is even more important when we're talking about implementation, because science will be shared only if there is somebody who can receive it and somebody who can implement it. Sorry, I'm not able to share my... Sorry. No, so I will go without slides. I think it's fine. So in 2018, we decided, in 2016, we decided to have a business plan on in ESO, where we decided that the most important part of this business plan is to work together with the patient organization. And, you know, we signed a memorandum of understanding together with John Barrick, because this was the first step, because we started in 2007 as a merely scientific organization. So the first step was to create a kind of let's say a connection with the patient organization. Then in our action plan we said, in our business plan we said, we have different pillars. One is the scientific, the guidelines. One is the collaboration with the patient organization, sorry, my cat. And the other is together with the political stakeholders. From this point on, we started to extend our scientific collaboration. For example, what ESO did, we endorsed the Burden of Stroke report, and together with John Barrick and other members of the national societies, we went to the European Parliament and presented this. Second, Urs Fischer designed a stroke implementation, let's say a survey over all Europe to understand what is the state of art in thrombolysis, thrombectomy, and even more important, in stroke unit care. So at this point, again, we had scientific data which were then published in the European Stroke Journal, but we needed to find, let's say, an appealing, important motto to get the stakeholders on our side. So you maybe remember the slogan that we created was, to have a stroke in Europe is like a lottery. You can be lucky if you are in Austria, where there's an excellent stroke network, or you can have more troubles when you are in some remote areas in South Italy. So where you don't have the stroke unit inside near you, and you will not get the stroke care, you will not get the thrombolysis, and you will not get even worse, a thrombectomy. Last initiative that we did, which was, I think, a very important initiative, was the one on stroke prevention. And Arlene was present. We presented the report of The Economist, where 5 countries were asked to give their inputs about stroke prevention. And you can see what we found is that stroke prevention is not equal in countries to countries. For example, in UK, we have excellent program that after the age of 40, you get your general physician will call you and ask you if you get your blood pressure measured. After 65, you will be asked to get your pulse measured. So together with The Economist and together with the member of the European Parliament, we had a Zoom meeting where we present these inequalities of stroke treatment in Europe. So just to share with you, we have, when we decide to have a political action, we have to divide this political action in what we call mapping. This is what we can do as scientists. We can report on what is going on, what is not going in the right way, because we are living with our patient. We are seeing what we are not able to give. Then we have the second phase, where is the understanding, and this needs to be done together with the politician, because you have to do a kind of lobby saying, I need you to have you on board, because it's my priority as physician. And if we are together with the patient organization, then it's the priority of the population, because alone as a physician, I will be always accused of having conflict of interest, because why should my patient be better or more treated than oncology patient. Why should we care for stroke? But when you bring the real stories, the single patient, the young patient who was not treated in the right hospital, then you create really the need of what your population is demanding. At this point, you can address inequalities. You can talk with your politician, you can design, and you can say, this can be part of your political program in order to create health. Because the politician will not, politicians are very difficult people. They will not ask, what can I do for you? But they will look at you and think, what can these physician, patient do to improve my election? But we have two different agendas, but this is not the point. These two different agendas, as a physician, wanting to deliver the best healthcare, the patient getting treated in the right way, and the politician to be re-elected need to go all together in order to overcome all the difficulties. And as a last point, I want to remind you that also in the European Action Plan, we wrote that politicians, industry, patients, physicians, and everybody who is involved in stroke care, and we are seeing now, especially in COVID, that we need more figures involved in care, because we will not be able to cover the care of our patient, like pharmacists. We will be needed. We will ask for more involvement, because if not, we cannot deal with the healthcare. So, in conclusion, I'm sorry for the slides that I could not show you, but the most important message for me to give you is that create an alliance, a therapeutic alliance with your patient, then extend this alliance to the politician, because this will definitely change the care for our patients. Thank you very much.
Thank you, Valeria, for sharing your experiences with us. This is very, very helpful for everybody, because none of us are primarily working with politicians, and that is what we're basically going to do now. So thank you very much. We will continue directly to the Histories of Success, and after these three histories, we will have a question and answers session by chat. And I'm happy to introduce the first speaker giving us his history of success in improving stroke care. And that is Professor Philipp Lehrer from Basel in Switzerland, who will talk to us about the Swiss certification project. This is not the only project he has led. He has always also been strongly involved into the stroke unit care working group in ESO, also sharing his experiences. Thank you, Philipp, for joining us today. Looking forward to hearing your presentation.
Hello to everybody. Thank you, Hanne, for your nice introduction. May I ask for the slides? Perfect. Thank you. So I will just ask the next when I'm finished with the slide, so we can move to the next one. Thank you. Actually, I was asked to talk about the certification program in Switzerland. So I will focus mainly on Switzerland, and I would like to show what was the way up to a really network over whole Switzerland of stroke units and stroke centers. So it started right away, actually in 2004, when we issued a national paper that was named Stroke Units in der Schweiz, Bedarfsanalyse, Richtlinien and Anforderungsprofil. So this means, what are stroke units? Do we need stroke units? Are there guidelines? And what should a stroke unit do? That was in 2004. What we had at this time were just a meta-analysis of stroke units that was issued some years earlier but nothing else. So that was the key point when we started. But it went on quite quickly. Then in 2007, I was mandated by the Swiss Neurological Society, being at this time the Secretary General, to start actually the political work if you want, but it was not direct political work. It was well regulated, as Switzerland was on the way to introduce diagnosis related group. So I was charged to deal out all diagnosis related groups for neurological treatment in hospitals over Switzerland. And this I did together with Ulrich Büttner, who was at this time head of the neurology department in Aarau. It's important to say that we were two of us, at least at the beginning. And then when it came to action, it was my person. And this was led by the Swiss Medical Federation, the statistical authorities, and the Ministry of Health. It ended in 2011, May 11th, when the decision for the committee for highly specialized medicine that exists in Switzerland as committee, who is delegated from all cantons, decided that the compress endarterectomy, interventional revascularization of stenotic cerebral arteries, and at this time already endovascular treatment of acute ischemic stroke is recognized highly specialized medicine, what means that it should be done in centers that are mandated by the authorities. So that was the first most important step. With this, it came in that we had to write down what the stroke unit and stroke centers will be. And this ended in 2012 in the Swiss Medical Forum, where we issued the first guidelines for stroke units and stroke centers in Switzerland. And this was together actually with the European Stroke Organization recommendation to establish a stroke unit and stroke center. In between this time, this was of course coordinated within the Swiss Stroke Society and within the Swiss Federation of Clinical Neurosociety. Actually, the Swiss Stroke Society took the, let's say, part of how it has to be, of the guidelines, and the Swiss Federation of Clinical Neurosociety is the political part. The next slide. Okay, and that's just to see you that these papers that were issued, and some of you are already here today, as I saw. So the role of the ESO that was not ESO at this time, was already very important for us in Switzerland. Next slide. Finally, we had the European Stroke Organization certification of stroke units and stroke centers paper that was recently issued, and that is still one of the key papers also for the certification process in Switzerland. Okay, next slide. Next slide, we continue. So here you see what is a stroke center. Oh, you have to click, you can click 3 times. Actually, a hospital infrastructure and related process of care that provide the full pathway of stroke unit care. It's important. That's from the, actually that's how it's also written in the ESO paper. A stroke center is a coordinating body of the entire chain of care. This covers pre-hospital care, ongoing rehabilitation and secondary prevention, and access to neurosurgical and vascular intervention. A stroke unit is the most important component of a stroke center. So a stroke unit is within a stroke center, but the stroke center is a coordinating body. So, and it works throughout the whole hospital. A certified stroke center provides stroke unit services for the population of its own catchment area and serves as a referral center for peripheral hospitals with certified stroke units in case their patients need services which are not available locally. That's important also from a political point of view, as you have a catchment area, like in Switzerland, you have a catchment area, let's say here in Basel for a city that is not very large, but other hospitals can send patients, and it's done with contracts. So we had to deal out contracts, and that's where it becomes very political, of course. And at this point, you have the hospital authorities as well as the political authorities involved. So it has many components. It's not just to build up the center. That's what we do. Please send us patients. So you have to be sure and to convince people to send patients to you and also to take them back. So the next slide, please. And yes, and you have to pray. Okay, thank you. And here you see what a stroke center is able to do and what a stroke unit within also a stroke center or a stroke unit in a smaller hospital is able to do, and how many beds and how many patients per year are the minimum, how it's defined. And you see it's very important to have intervention 24/7. It's very important to have all diagnostic tools 24/7. It's very important that the stroke unit is also able to provide cerebrovascular CT scanning 24/7, and so to be able to ship patients to the stroke center. That's how it works in Switzerland. Of course, there may be some other models. The minimum is not huge data. Actually, the stroke centers in Basel, in Switzerland, they have 6 up to 12 beds, and mostly they treat about 800 to 1,200 up to 1,800 patients a year. The next slide. Okay, yes, so the political requirement was coordination of highly specialized medical services. What is not for every patient, but it was interesting and important to provide it nationwide. So stroke care in Switzerland is part of a highly specialized medical service. And the mandate by politicians was transferred by the Swiss Conference of Cantonal Ministers of Public Health. So actually, that was the main part, to reunion all these cantons with the same idea for treatment of stroke. So we had to convince 26 governments, as you may count on this slide, because the medical system in Switzerland is not centrally ruled as when it comes to what you are doing on your everyday basis and how to conduct hospitals. Okay, next slide. So how to do it? So actually, it's a type of work that can be depicted from any type of planning process. So plan it, design your stroke care facility, develop all relevant SOP. That's very important, to develop standard operating procedures. So to write down what are you doing for which situation exactly. Start it up, optimize, and then apply for certification. That's the do. Check here, get the certification done with audit, with site visit. Act, continue treating your patients according to your corrected standards. So you may correct within your action plan, create data, that's very important, and search for benchmarking. Actually, that is important, so to nivellate the niveau of the treatment. So this is for the first certification. Then recertification, that's on the next slide. It just continues this way. Revise design of your stroke care facility and all relevant SOPs. Be aware from the certification you get some advice what has to be changed and what has to be better. Correct pathways, optimize, and apply for recertification after, of course, a defined time. get recertification with audits, maybe with site visits, continue treating your patients, benchmarking, create data, etc. And implement improvements that are also coming from the literature. Next slide. Now, what are the certification criteria? What should be checked when you are certifying or when you are being certified? Actually, of course, behind this, there's a whole organization that I will show on the next slides. But very important is the A, B, C, D, E, F, G of the certification mode in Switzerland. It's A, the lead. Who has the lead? And that's very important, as you may be aware. Mostly it's neurology departments who has the lead, but it can also be medical departments. But it's important to define clearly who has the lead and what type of physician it is. We in Switzerland, we defined it for neurologists. Then the personnel, how many people are doing what for your patients, the 24/7-hour shifts and so on. Personnel for nurses is very important, physiotherapists, etc. Everything has to be named, and also schedules for duties has to be defined. Write down the infrastructure. What is where in your hospital and how do you reach it? That's very important. Has to be written down. How are you doing investigation, MRI, CT, ultrasound, laboratory, ECG, echocardiography, etc. What type of interventions are you providing? Write down exactly how you proceed to make an endovascular treatment, to make a systemic thrombolysis, to make a combination of it. What to do if it's not necessary or not indicated to do. How the patient then is transferred to rehabilitation. This all needs teachings, defined meetings, and also research. And that's why I wrote down that's then mainly the part of the Swiss Stroke Society, while numbers, quality indicators, and the certification process, this comes out, and the indicators comes out from the Swiss Stroke Registry that was, by the way, built up together with upbuilding the certification process. Okay, next slide. So you got a lot of documents. Who is the lead? Personnel, SOP, infrastructure, plans. And once you have everything ready, next slide, you go and ask for audit. And then I will show you how this works. Next slide. So the aim is quality improvement for centers and units, have concepts and regulations, defined process, and the most important thing, to have an audit by peers. The peers that are auditing by actually in a very defined way will be stroke experts. So people coming, actually your friends from the Stroke Society coming to your hospital and checking what you are doing. So you have to open up your infrastructures to people coming from the outside that are experts by themselves. And of course, this will happen vice versa. Then the documents will be seen on on-site visit. Usually it starts with an opening ceremony. Actually, this is a debriefing. Then with interviews, then with an on-site visit, and then with talking the results of the visit, writing an audit report, and the audit report is finally voted by the Swiss Federation of Clinical Neurosocieties that runs a stroke committee. That's the main task of this stroke committee. And finally, it comes back with the report and the feedback and the result if you are successfully audited or not. Next slide. And how does this work? Actually, we created quality criteria that are evaluated by points. There are two principles. There are the must criteria. This means they have to be fulfilled. If not, you fail. There are not that much must criteria, but there are some. And then there are the additional criteria that will be graded. And for these, you have to have at least a certain number of the overall points. And the number you have to reach can be defined by the stroke unit committee in Switzerland from the Swiss Federation of Clinical Neuro Societies. Usually it's about 80 points. Most stroke centers or stroke units have 85 to 100% of the points, and that's okay. This means all are up to date and fulfill the criteria. We do not want them to fail. We want them to fulfill the criteria to have actually the network in Switzerland. Next slide, please. So here it's how it comes out. Like actually, this is out from the ESO certification process, but it's mainly the same for the Swiss process. I just didn't translate it, but it's how it looked like. And that's the checklist that also the auditors have. And then there is another column where they write down their observation while performing the on-site visit. Next slide. Here you saw the one for the stroke units, here the one for the stroke centers, and the corresponding numbers, but just as example. Next slide. The assessors or auditors, actually it's very important that they strictly adhere to the certification criteria. They are stroke experts. They exactly know what is necessary, but of course they are doing the same job like you do. Finally, you get out recommendations, and these are finally the decisions or is the basis of the decision by the certification committee. Usually we have 3 auditors, 1 leading auditors. This is from Sanazert. Actually, that's a company who is doing audits, actually starting originally for oncology, and now one big part is stroke certifications. And we have the 2 experts, the peers that are leaders of stroke units or stroke centers, either neurologists, neurosurgeons, or the neuroradiologists. And sometimes we also have guests that are not allowed to vote. Okay, next slide. Yes, and the whole certification process can be seen on the website of the SFCNS. Next slide. That's the same. This comes from the homepage of the SFCNS. This you can read there. I just wanted to show that this exists and everything is well defined and is official. Next slide. The way to do it, here you see the time scale. Actually, the first certification process takes almost 3/4 of a year. So it's quite a lot of work. The recertification process, it's much shorter. Next slide. Actually, this I will summarize in the last slide. So you can jump once, you can continue. The next slide. So now that's how it looks like now in Switzerland with the stroke centers that are 10, the blue one, and the stroke units that are 13, that all work together and have their network. Next slide. And if you come to the results of the Swiss Stroke Registry, here you see by every city, village, etc., the number of cases that are sent to stroke unit care over Switzerland. And so you see within the Alps, there are some white spots where no strokes occurred, but otherwise it's becoming more and more red over the years. Next slide. Yes, and that's finally what comes out. Okay, next slide. So I come to the summary. It's certification. The certification process in Switzerland is an ongoing process that never ends. So you are always in, you certify, you recertify. It sets standards of care for the whole country, enables benchmarking, builds up networks locally and nationally, creates a lot of data that can be used also for research, but the primary aim is for quality control, facilitates research and creates excellence. And I think that's exactly what our patients need to get the best available and affordable care if they have a stroke. Okay, thank you for your attention.
And thank you, Philip, for giving this very clear and detailed presentation. We will continue right away, and it's my pleasure to introduce my Danish colleague, Dr. Dorte Damgaard from Aarhus, who is here in her capacity as being chair of the board of the Danish Stroke Quality Program, which is a very different model from the one we just had presented from Switzerland. Thank you, Dorte, for joining us today. Looking forward to hearing your presentation.
Thank you very much, and thank you for the invitation. And I'm going to present the Danish Stroke Register on behalf of myself and my co-chairman, Peter Vögel, who is an occupational therapist and the steering committee of the Danish Stroke Register. Next slide, please. The aim of the Stroke Register is, of course, to improve the quality of care of patients with acute stroke and TIA by measuring implementation of national clinical guidelines. It was started back in 2003, and it was initiated by the owners of the hospitals. The healthcare in Denmark is primarily public. A national multidisciplinary steering committee of stroke specialists was established. Next slide, please. And a set of process indicators were developed from national multidisciplinary stroke guidelines. As time is brain, a time frame for the single indicator was defined, standards of good quality were defined, and the register was from the beginning very ambitious, with focus on good quality of care, not on what is possible on a given time point for practical or organizational reasons. In the beginning, one effect indicator was chosen. It was 30 days mortality. And a goal is that more than 90% of patients with stroke in Denmark should be in the register. And this has been achieved, but it has a goal we have continuously to be aware of. Next slide, please. Here is the process indicators we had in the register from the beginning. As you can see, which I still think is one of the most important, is to get admitted to a stroke unit. For this presentation, I will go through 3 examples: evaluation by physiotherapists, operation of symptomatic carotid stenosis, and as later on new treatments were introduced, we also have been measuring reperfusion therapy, and I'm going to talk about the proportion of ischemic stroke patients receiving reperfusion therapy. Next slide, please. Denmark is a small country, a little bit less than 6 million inhabitants. We have the country is divided in 5 regions, and these 5 regions are the owners of the hospital healthcare system. We have 98 municipalities. On the right of the slide, I've shown the measurement of evaluation by a physiotherapist on day 2, when you are admitted with a stroke, and the standard for that has been set to 90%. It is possible when you register your data to say that this is not relevant for the given patient. And that's why that we have set these quite high standards. For the patients we think it's relevant, it should be done in at least 90%. As you can see from the slide, this is the filled red line is the total of Denmark, and the other lines are the 5 regions. We also collect data for the single hospitals, and they are shown in the reports. As you can see, it took many years to achieve the goal, and it turned out that it was not possible to achieve this goal before therapists also were on duty during the weekends. I think it also illustrates that even though we in 2014 achieved the standard, it is an indicator which has to be monitored continuously, because there is a risk, even though you have got a good quality, that it drops again for different reasons. Next slide, please. This is another example. It's operation of symptomatic carotid stenosis within 14 days after admission to hospital. And here again, based on the guidelines, which tells us and the evidence that the benefit of operation for carotid stenosis is largest if it's done early. And the standard has been set to 90%. I would like you to focus on the northern part of Jutland with the dark green line, where you can see in 2012 it was only 45% of patients who were operated within 14 days. At that time, stroke patients in the northern Jutland were admitted to 5 different hospitals. They were all stroke units, but only the one big in the middle was a department of neurology, and also only in this hospital there was a department of vascular surgeons. They have established a very good collaboration, but it was quite hard to get the patients from the local hospitals to the central hospital in time. There was more reasons, but this was one of the reasons that in the northern part of Jutland decided to centralize the acute treatment of stroke patients, so that all patients were admitted to the large central hospital. And as you can see, in 2013, the year after the centralization, they almost achieved the standard, and has now been the region in Denmark who operates most patients within 2 weeks. Next slide, please. During the last 10 years, reperfusion therapy has been increasing as an important treatment, and it was in Denmark. Full thrombolysis were fully implemented in Denmark 2008, and the quality of reperfusion therapy were monitored in the Danish Stroke Register since 2011. And as you can see from the table here, that the proportion of patients with acute ischemic stroke receiving thrombolysis are quite high, from 13 to 15% when we look at the whole, if we look at Denmark as a whole. But we also were aware that there was variation geographically. As you can see here, some regions it was 11%, in other regions it was 18%, and there was quite large variation between the municipalities. The next slide, please. this is an example, I think, that how you present your data matters, how to interpret it and discover variation. Before 2015, the proportion of patients receiving a reperfusion therapy was listed in tables, like you can see on the left. But from 2015 and on, it has been illustrated by these maps of Denmark with the 98 municipalities. And if it's orange, it's below 15%. If it's green, it's above 15%. The dark orange, it's below 10%, and the dark green is above 20%. So it became more obviously that there was some geographical variations and which could not be explained solely by differences in patients, because Denmark is a quite small country and also quite a homogeneous population. Next slide, please. There was a new quality program in the whole healthcare system in Denmark, and stroke was a part of this, where learning and quality teams in every region were established, and we have already heard about the PDSA method. It was used to look upon all the steps in getting the patients from their home into the getting the ambulance at the right time, getting into the right hospitals, and get started reperfusion therapy as fast as possible. So it was also a collaboration with the pre-hospital setting. There was parallel with that national meetings with exchange of experiences. In the beginning, the standard of reperfusion therapy in Denmark was 10%, but with also introduction of thrombectomy, it was increased in 2016 to 20%, and later on we also have got evidence for thrombectomy in the late hours and thrombolysis in patients with unknown onset, and this standard has been increased to 25%. Next slide, please. I'm happy to show that the proportion of patients receiving reperfusion therapy, thrombolysis and or thrombectomy has increased from 16% in 2015 to 24% in 2019, and I think the combination of measuring and having data and this quality program has facilitated the speed and the speed of implementation of the new treatments as thrombectomy and thrombolysis in a late window as well. And as you also can see from these maps, that the variation due to the geographical variation has decreased. Next slide, please. This is a slide I have borrowed from a colleague who is an epidemiologist and who has been with us from the beginning in the Danish Stroke Registry, and it shows in the middle that every Dane has a civil personal registration number, and by this number we can combine data from different registers and also the Danish Stroke Registry. Next slide, please. And we have been evaluating these indicators. We have been measuring during the years also in a scientifically way, and this slide shows that as the number of process indicators fulfilled increases, the mortality is reduced. Next slide, please. And this paper also shows that the more fulfilling the process indicators decrease also the length of hospital stay and thereby hospital costs. Next slide, please. In 2000 and in the last 10 years, there has been an quite large centralization, and I will claim that this has been to a high degree been driven by data, especially in the western part of Denmark, where we have had fewer neurologists, and so there has been a movement of patients with stroke being admitted directly to departments of neurologists, with possibilities both for thrombolysis and also for thrombectomy. We have right now been evaluating outpatient clinics, and this is under publications, these data, so I can't show them, but have also shown that we have been able to improve quality of care without increasing the risk of re-stroke in patients with minor stroke or TIA. And have been able at the same time to reduce the length of stay. Next slide, please. And very luckily, and I think of course that is not only because of the Danish Stroke Registry, but because of all these new treatments for stroke patients, we can measure that the mortality has decreased during these last 14-15 years. Next slide, please. Future direction. The Stroke Register has until now been focusing on the acute care, but we are going to move also into evaluate rehabilitation that is offered to stroke patients, and we are going to measure how many patients who are going home from the hospital and to the primary care has a plan for rehabilitation at that time. We are also going to measure a functional outcome by using the modified ranking scale, which is a simple scale, but the reason we have chosen that scale is that we think if we are going to measure or evaluate functional outcome, and if we should be able to evaluate the rehabilitation the patient get, we need to have as many patients in the register and data and as many patients as possible. We'll start after 3 months, but of course it will be relevant also to get data after 1 year. And another thing is that we have, during the last couple of years, have had a patient with subarachnoid hemorrhage included as well, and it has been very positive to see how engaged the Danish departments of neurosurgery have become after we also have included this patient group, and I think it could be a benefit also to patients with intracerebral hemorrhage. Thank you.
Thank you, Dorte, very much for presenting this different model of how to improve stroke care. We're going to right away continue with Robert Mikulik from the Czech Republic. We're a bit behind time, and but we will still have a very short question and answer session after Robert's presentation. Welcome, Robert, and you will present the ESO-East project and also tell us a little bit about the Rescue Registry, which is a certain model of how to work with improving stroke care.
Hello, Hannah. Hello, everybody. Thank you very much. Can you hear me? Okay, very good. So it's my pleasure. I can present what we have done, with the ESO-East. I think that many of these, things were already presented, and as you said, we are behind the schedule. So I will be pretty short. I think that actually the philosophy with the rescue is very similar to what you are doing, with the Danish registry. So the philosophy is basically the same. But anyway, ESO-East was started to improve the quality in Eastern European countries. This is the copy-paste from the ESO website, so you can read more about the goals and aims of the ESO-East. Now, basically, since the beginning, we were focused on two actions. One was to develop an infrastructure or the network of people who will actually conduct the quality improvement itself. And the idea was that we have the connection between the leadership and between healthcare professionals using different tools, such as communication, of course. And then the second action was to develop a registry and start quality monitoring to identify the gaps in the stroke care quality, to benchmark hospitals against each other's, countries against each other's, and of course, develop some country and hospital-specific interventions to improve the quality of stroke care. So in terms of the network of people, this is, that's the network, and we usually meet just before the ESOC. This year is, of course, different, but you see the number of the people that has been involved and how they are growing. So these are mostly national coordinators, and the idea was that each national coordinator will set up some task force, in his or her own country, so some steering committee that will conduct the quality improvement itself. And these are the numbers of the members of the steering committee in different countries, as it was actually last year. And so that was the first part. The second part was, once we have all this network of the people, we have the connection to the hospitals, we will start to measure the quality. And we developed the registry, the rescue. You probably know, these are the basic metrics of the registry. When we presented data during ESOC last year, there were 55 countries, more than 700 stroke centers around the world, and 94,000 patients. And these are the numbers, in September 2000, this is this year actually, September 2020 and November 2020. So you'll see that, for example, from September, we enrolled around 30,000 patients from 70 countries. And also the number of the hospitals is, 60 more now than it was in September. So we are increasing number of the hospitals, number of the patients. Now, rescue offers not many, but I think that the important functionalities that I believe motivate people to use this registry. First of all, it's designed to have very simple, easy data entrance form. So it's basically one-page document where you enter the data, and it doesn't take long as you have data available to you. Then there is a one-page, which I would call national audit tool. So this will give you the snapshot of the quality of stroke care in your country. So here, that's the example from the Czech Republic. We have all stroke centers, and these data are updated every hour. So in a way, we have a tool how we can monitor the quality of stroke care at the country level, basically continuously. And there is the hospital benchmarking tool. So each hospital can compare either with some national median or with the other hospitals. And then there is a reports and data download tool. So you can download data in different formats, such as the source data or PowerPoint presentations. So in conclusion, we succeeded to establish a management structure for international quality improvement program. We developed an implemented platform for quality monitoring and feedback within the ESO-East. We started to measure quality of stroke services in many countries around the world. Now, in many countries, we have an excellent representativeness, but not in all these 70 countries. In most of the countries, we have some stroke centers that participate. Most of them do not participate. So we still have, in a way, scientifically biased data. And this is something definitely that we all of us should aim to improve. And I believe that all of us laid the foundation for implementation of European Stroke Action Plan. And I really would like to give big thanks to everybody who contributed. There are a lot of people who contributed to this effort, and they are part of this teleconference, and also, they're around the world. So thank you very much.
And thank you, Robert, for this very clear and useful presentation, and also for keeping time.
Yeah.
We now have time for a short question and answer by the chat. Professor Fischer will chair this, and we will have time for 2 or 3 questions. So please, Urs.
Yeah, thank you, Hanne. So unfortunately, up to now, there are no questions in the chat. However, I would really like to ask all participants, be free, use the chat function, send me an email or send us an email. There is one coming in here. So for George, great to hear that the register will move on into the rehab data collection. Will the data be for hospital rehab, or will it include community rehab as well? So could you please answer this question?
Yes, to begin with, we will start having data about the functional outcome, and we think this is where to start. And because now in principle we only know if the patient is dead or alive. Then we will, as I said, we'll start with a 3 month after 3 months after the stroke. But of course, it will be very important also to get data later on, because especially rehabilitation also in the community will be in the long run. So we won't start collect data on rehabilitation per se, but we'll start collecting data on a functional outcome, and also to see, is there large differences, is there large variation? So how well the stroke patients are after a certain period of time. Now I have illustrated that the acute therapy is a high quality in Denmark, and there's only small variation due to where you live. So if there's variation upon how many patients who are able to take care of themselves and in a significant way, then we have to go to look upon the kind of rehabilitation the patients are getting after the stay at hospitals.
Okay, there was also a comment from Peter Kelly. So first of all, he congratulated you for the great presentation. And the question was, is there a financial incentive from the healthcare system for quality improvement goals for stroke? And do you think whether this matters?
There is no directly financial interest, but also, as I have shown you, that the administrative and political system are quite interested in these data, and there is department that I will claim has been closed due to not maybe bad quality, but not as good quality as other hospitals.
Yeah. There is also another question to you.
May I add to this?
Sorry?
May I add to this, because I think that it went to everyone, this question from Peter Kelly. I am not aware that there is any financial incentives, in countries that participate in rescue. And I think that the first line of the incentive should be actually to incentivize hospitals to participate in quality improvement. And only the second line is to achieve certain goals. But I think that that's really important, that in a way we are building, the system from the bottom up. And we need to sell this idea to politicians and then to create the incentives. And I believe that will be important, of course.
Thank you very much for this very important comment. There is another question to Dorte from Janika Kör from Estonia. The question is, who will be responsible for collecting modified ranking scale data at 3 months?
It will be the hospitals, it will be the regions. Of course, would be wonderful if we could involve the communities, the primary care. We have been worked on that for years, and we think it's unrealistic at this time. So we have said now we need to get this information, and of course it is going to take a time before we have data for all these patients, but we think that it is reasonable that you are in contact with the hospital at least once after you have been admitted to a hospital with a stroke, and during this contact control we could get data about the modified ranking scale. And the reason we also chosen this scale is that information can be achieved by talking to relatives or care people if the patients are not able to respond by themselves.
Thank you very much. For the sake of time, we have time for one last question to Philipp Lear from Basel. The question is coming from Nathan Bornstein. The question is, are the Swiss stroke center equally geographically distributed throughout the country?
Yes and no. I can say yes for where people are living in Switzerland. So there are spots, and I showed some white spots. Actually, these are in the mountains. So there are some rural parts of Switzerland where the next stroke unit or the next stroke center is quite far away, at least by means of car driving. But it's possible to build up networks also with smaller hospitals, and by helicopter flying, I would say usually within 1 hour, you are in a big center from wherever you are in Switzerland. So directly covered, I think probably have about 85% of the population is covered either by stroke units or stroke centers with direct access.
Thank you very much. So I'm handing now back to Hanne.
Thank you, Urs. We have to proceed in the interest of time. I've noticed there were a lot of very interesting questions, and we will find a way to get these answered or to get this good discussion continuing. Now it's my pleasure to introduce the next talker, Francesca Romana Pezzella, one of my 2 co-chairs from the steering committee, who will go through the tasks of the national coordinators with you now. And this is very important because this will be one of the major topics in the regional breakout sessions later, where we want your feedback because we needed to, to fine tune the program. Thank you, Francesca Romana, for giving this talk. Looking forward to hearing it.
Thank you very much, Hanne. Oh yeah, it's asking, yes, you can, yeah, because. So thank you very much. As I said, I'm really happy to be here today again with you. And as Hanne said, the tasks of national coordinators will be object of discussion during the breakout sessions. So we can look at the major points here now during this, the next 10 minutes. Next slide, please. Next slide. So you see, this is a very nice slide that was prepared by Diana, and I really like it very much because it presents all the activities of the action plan that has to be taken in order to implement our goals and to reach, of course, them by 2030. Now, what is the role of the national coordinator? We imagine that the national coordinator in each country is the main person or the group of persons to advocate for the SAP-E and make the attention of stakeholders coalesce into these objectives. It has a very important role in terms of communication, in terms of contributing to the National Stroke Plan, which is one of the key performance indicators that we have chosen. The national coordinators or coordinator should tune the strategies for implementation and manage all the efforts and contributions in order to reach our goal. It's we imagine that this group of people is a group of people that influence the environment, they influence the stakeholders in order to motivate them, in order to make them understanding the importance of the stroke plan implementation. And of course, it's the trade union between us and so the implementation committee and the various countries. So it's a really a strategic role, as it has a really strategic activities to carry on. Next slide, please. So now you will see some slides that I have prepared in order to present the activities that we would like the national coordinators to carry on. The first thing is to assess and monitor national and regional situations. You have heard about the registries, you have heard about the certification system, and of course about auditor and monitoring, that it's the backbone of the quality system in Europe. We are going to discuss in the next rollout meeting the SAP-E data platform, where the national coordinator is supposed to upload the data and of course to analyze the output and discuss them at a national and of course European level. And it's very important for us, and I was very grateful for Robert to present the rescue, and to also to Dort to present the Danish registries, as these are very important examples that we should keep into consideration. Next slide, please. The stakeholder analysis is probably one of the critical activities that we will ask you to carry on as one of the first things to do. When we talk about stakeholder analysis, we ask you to see in your countries which are the possible main players that could help in implement the action plan. So the professional associations, scientific societies, patient support groups and associations, all the decisions and policy makers, public managers, all those people that could have an opportunity to achieve results that action plan can benefit of. And of course, and for us, it's very important that we can help you in giving you all the tools that can be useful for you in order to understand the context where you're working and to understand what are the main players that we should reach out in order to reach our goals. Next slide, please. In order to have the major engagement of the stakeholders, we are preparing, and we will be discussing this in the next rollout meetings and within times, a SAP-E declaration. The declaration is a tool that it's a common decision plan. So it's a tool that we can use in order to engage Ministry of Health and regional leaders, and that can help in making the difference between drafting a plan and making it happen. So it's very important for us also that you stay with us while preparing and discussing the SAP-E declaration, and you will hear more about this in the next meeting. For us, it's also very important that you start in the analysis of the stakeholders, you start seeing what are the possible resources that can be mobilized in your countries, and we could help you, and how this is also a way that you could feedback us on, is a topic you could feedback us on, in order to have the possibility to start a series of communication and dissemination activities that can be useful to advocate for the plan. Next slide, please. This is, I think, a very critical point in the action plan strategy. So it's setting up a country-based network and work groups. Building a team, as you can imagine, is really building I would say, the nervous system of the action plan implementation strategy. The national coordinators are accountable for the selection of the team, which is effective in promoting the agreed change. And what you are driving the change in your countries through the network that you are able to implement. And the network, of course, should be multidisciplinary, multi-professional. You should have diverse in background, and the network should reflect the range of action lines that are in the plan. So not only looking into the stroke professional societies or the stroke support organization, but also reach out for other possible players that could help. Next, please. So what we ask is build a case. Build the case of the action plan. It means that it's of critical importance that the action plan is given the attention and priority that will ensure its successful implementation. And so building a case in your country, it's not only involving the stakeholders, but it's also disseminating the informations and capturing the attention of the public, even though there are hard times, tough times, like during the COVID pandemic. Then next slide, please. So maintaining information, giving news on the process, on the result is really critical. And again, for us, the national leaders have the role of navigators of the change in the programs. And of course, we know that each country has a different situations, and so it's very important for us that after you have examined your context and you have made a context analysis, an environmental context analysis, you may decide what are the targets and the priorities that should be reached in order to achieve the final overarching action plan goal. Next slide, please. I don't need to talk about pressure that we had from the COVID-19, and of course this has driven away the attention from stroke and from other conditions, other non-communicable disease conditions. But this should not drive away our attention and our efforts. And from this, I think there are very interesting experiences that I've asked some countries to share in the breakout sessions, and this will really be helpful for us, because we can see how even in hard times we can still keep working on stroke. Next slide, please. So I'm about to end, but again, I would like to highlight the importance of the monitoring and report progress, and so the use of the registries that are in absolutely key tools to reach an improvement in the quality of stroke care, and the importance of certification, accreditation. Next slide, please. So this is my last slide, and this is just to throw some ideas on how to reconcile with the ISAP targets and what we recommend also to do from a practical point of view. For example, is to organize an annual meeting with national coordinator on benchmarking results in each country, to drive surveys and reviews that should be conducted in each country with periodicity that should be consistent with the SAP-E general framework at European level. Thank you very much. I've finished.
Thank you very much, Francesca, for this short but still very comprehensive overview of the task of the national coordinator, which will also be discussed in the regional breakout sessions. We will continue directly with my other co-chair, Arlene Wilkie from SAFE, who will talk on how and why to ensure patient involvement, also reflecting perhaps some of the points in Valeria's introducing talk. Looking forward to hear what you'll say, Arlene.
Good afternoon, everybody. I am delighted to be here. I think we've got about 95 attendees today, which is absolutely fantastic, from national scientific societies and stroke support organisations. So I'm really glad to see you all here. So move on to the next slide, please. When I was asked to give this presentation, my personal thoughts were, why wouldn't we involve patients in the decision making on their care? We are in the 21st century. Why are we not doing this as the norm? So I struggled a little bit to deliver my presentation. Patients are the ones that live and breathe their health conditions, so why would they not be involved? In addition, that lived experience plus the data and the evidence that has already been described today, so from the registry data, for example, I think that lived experience plus all that hard scientific data is the strongest message that you will have to take to your ministers to demonstrate that need for change. And even yesterday, I was on a virtual call with MEPs from the Brain, Mind and Pain Interest Group at the European Union, and the director of the Department of Non-Communicable Diseases from the WHO. She was even talking about patient involvement and said, nothing for us without us. People living with or affected by NCDs must have a seat at the decision-making table. So there is the rhetoric, patients must be involved, but what's the reality? So I decided to contact SAFE's member organisations. I thought I would reach out to them and ask them, is this happening in their countries? And a lot of their feedback has informed the next couple of slides that I have for you. So I heard back from the Ukraine, Macedonia, Serbia, Croatia, Cyprus, Italy, Catalonia, UK, Finland. So I got a lot of feedback from all over Europe, and the response was varied. From Finland, for example, there is the Patient Act, which outlines patients must be involved, to perhaps no involvement in the likes of countries like Cyprus, for example. And I was only able to find few pieces of guidance and research that I've put up on this slide here, which could actually help and guide you as to how to do this well. So I think there's more work still to be done, I think, and the overall response from the patient organisations, the stroke support organisations that I spoke to, is they really want to be involved in this. So they want to be involved, and they want to make this happen. So first of all, I thought I would just listen to the views of the stroke support organisations and actually try and understand why it's not happening. So on the next slide, I kind of outline this, that there are challenges that you will face when involving patients and implementing a national stroke plan. And I also thought it was important, it reflects a little bit about what Francesca said, that there are actual issues even before you want to involve patients. Involving stroke itself, talking about stroke and getting that as a priority is going to be challenging for you because of the dominance of the likes of cancer and diabetes and other conditions. So I think that is something that we should reflect. Politicians will always say that they can't support single disease conditions like stroke. Well, I think if they can talk about conditions like cancer and diabetes, I think they can definitely talk about a condition like stroke. You will also have issues in your health and political structures. Again, Francesca did touch on this. So for example, in Germany, you do have a common health strategy, but you have 16 federal state ministries who will also have their say. So that's a challenge within your country. In addition, when you might get some buy-in by your ministry, ministries change, new governments get brought in, and so the whole teams might change, which again may change their approach to your stroke plan. And you all also know that general elections have happened across Europe this year, and again, contacts will change. So these are the kind of the political and health issues that you may face implementing your stroke plan. In terms of patients, let's come back to the patient side of things. So there's a cultural challenge that you will have in that you have the health system itself, where we have a situation. Hospitals were set up years and years and years ago to fix issues, and now people are living longer. They're living longer with chronic conditions. So there is a movement away in some countries from maybe professionals controlling that care to it being a shared responsibility. So this is between the healthcare workers and the patients making those decisions. However, this does require a cultural change, and it does require that relationship between the health system providers and the staff and the patients to transform that way of working so that we can fully engage patients and the public to improve the health and care. So that's kind of your cultural change as well we need to address. And as Francesca has touched on as well, an issue that you're facing just now is capacity, experience, resource to actually make this happen. So you have the pandemic. Many people from the stroke support organisation said they had meetings with ministers booked in to go and meet them, but the pandemic has meant that they haven't been able to meet them. In addition, the pandemic has meant a focus on infectious diseases, and overnight, health systems changed overnight without patient involvement.
Vanessa, ti dico solo che c'ho te in un orecchio e Arlene Wilkie nell'altro.
Sorry, I will continue. So overnight, healthcare systems changed without patient involvement or consultation. And as Francesca said, getting the right people in your group, so doing that stakeholder analysis is so important. Medics, therapists, patients, stroke support organisations, bringing everyone together is so important. And what you'll need to consider then, of course, is people's time. People will have to be spending time on this, and so that's an additional challenge as well. Now, those are the challenges, and that was reflected by the conversations already and from the stroke support organisations that I reached out to. So now I just want to move on to two more slides, so that the next one is about what would be good practice in terms of getting patients and stroke support organisations involved. Now, this is a busy slide. I thought it was important to see the detail because I hope these are going to be circulated afterwards, but these might be principles of participation that you might want to use as a committee, and not actually just for patients and stroke support organisations, but I think for all your members. So I think it's important to reach out to people people might not necessarily know who the coordinators are and what's going on. So please reach out. Please make sure you are looking for people that have got experience in the health issues that you're talking about. Look for inclusion and make sure we are valuing people's lived experience. Once you have your group, be really clear in what it is you're communicating. From a stroke survivor point of view, for example, you may be working with people who have aphasia or communication issues. So do make sure that you're considering that in your communication. Take time to plan. This is really important. People are busy. People need to make sure they need to know what's happening so they can really participate and feel valued in the work that they're doing. Be open and transparent. So all of those points above are talking about investing. If you invest well, think about what people want and need and how to communicate, you should have a really strong group. And what this will do from the patient point of view, which we often see, is we want to avoid tokenism. So we want to make sure that the patient and the stroke support organisations feel at the heart and centre of the work that you're doing, and to avoid that tokenism. So it's not just a tick box to say we've involved patients. Once you've got your work all going, review it. Review from the positives, look at the negatives as well, learn from it all. Celebrate people's work. That will add value and keep people involved in what you're doing. And I think finally on this slide, set up actions that are ambitious and achievable, but also measurable, because that will really help your politicians see what's being achieved, and it will also help draw people into your group as well. So just on my next slide, you will want to know where can you get information on patient experience. So I've just listed a few points here. There'll be surveys, whether at the European level, your country level, or even more locally. Look at those. The Stroke Association, for example, have done a really good patient experience survey recently, and I'll look to share that with you because I think it might be, the basis of some work you may want to do yourselves. Research reports, so the Canadian report that I added in at the beginning, that's a good example of how to do patient involvement and experience very well. You may have your own local intelligence so that there may be information from health services, community services. The stroke support organisations may also have done some research so they can feed back to you. Staff working in health services, they're a good source. And we've talked a lot about patient experience and getting their views. Staff also interact with patients and the public a lot as well. So they may also have some feedback that will help you as well. And you can read the other examples that I've listed there. So just finally, I think on my last slide, whilst I outlined the challenges, I do believe that by having you all together today, by understanding the need for data, and also by understanding the absolute need for having patients involved in this, I do think we can work together and really make sure that we're implementing the Stroke Action Plan together. And I think you can see some quotes there from our stroke support organisations. I particularly like the one from Portugal that says, "Stroke survivors will never quit, and we will keep on working." So on my final slide, I'd just like to say thank you for listening. That is my email address if anybody wants to reach out to me or to talk about patient involvement. But good luck, and I'm looking forward to working with everybody on this.
Thank you, Arlene, for this very instructive, comprehensive talk on this, which is perhaps quite a difficult subject, as you also said, but very, very important because we all have a lot to learn in this field. So being very practical about it, I really appreciate that. Now I'd like to give the word to Urs. I hope we have some good questions coming up on the chat.
Not yet. Apologies. Please use the chat function. There is one a comment coming in. Great presentation, Adeline. Well, which I can completely agree on. Please use the chat function to ask questions. So if this is not the case, I would suggest that we move on.
Yes, I completely agree. And this is very practical because we was a little bit behind schedule. Now we have a short break before the regional breakout sessions. And we will, you just stay on the same line. Everything technical should be managed for everybody. And then we meet again at 1:50 Central European time. Hope it is clear for everybody who are not in Central European time when it will be for you. Looking forward to seeing you back. You should all have been divided into groups, which are north, east, south, and west. And we've been a little bit creative about it because the numbers of countries in these regions are not the same. The idea is, and we have also for each of these groups appointed a regional lead who will be the one who will gathering the comments, the discussions, putting it into a few PowerPoint slides to present for everybody in the plenary session afterwards. I'm looking very much forward to hearing your feedback. When going through the 4 topics which we have listed, we might have made a slight overshoot, and I would please ask you to focus only on tasks of national lead, involvement of health authorities, and patient involvement. That is far more than enough for an hour of for less than an hour of discussion. So we'll meet back you should just stay on the same line, and the regional breakout session will start at 1:50 Central European time. Thank you.
Hanne, just a question, is it possible? Is there a specific link for each region?
No, that's not a link. It should be put into the link. We all have individual links, and I've been told from the technicians that if we just stay on our link, we will end up where we shall be.
Hannah, okay. It's Richard from Open Audience here. Just to explain, so when everyone returns from their break, once we've been given the nod to open the breakout rooms, we'll automatically move everyone to their relevant rooms that they've been assigned.
So have a nice break.
Okay, thank you.
Richard, I'm back online. Shall I?
Hello.
Hello.
This is George Tsivgoulis.
Hi, George. They will direct us in the breakout session now, I suppose.
Yes, I hope so.
Hello, I'm Michele Cagliofre. Hi.
Hi.
Hi, George. Hi, Francesca. Hi, Urs.
Hi.
Hi, Anna.
Hi.
Anna, are you good for us to press go?
Pardon?
Hannah, are you good for us to open the rooms?
Yes. Yes, please open the rooms.
Hello, do you hear me?
Yeah.
Yeah. So we supplied.
Hello, everybody. You have just been transferred to the plenary session from the regional meeting room. So just be aware that you're now in the plenary with everybody, and I would kindly ask everybody to shut off their microphones when not speaking. I wonder, and I'm talking a little bit to Leslie, can I assume everybody's here?
Yes, they all seem to be back. We've got 80 people back in the main room.
Yes,
Great,
breakout rooms. There's no one in any of the breakout rooms currently.
Thank you very much. Because then I want to welcome you back to the plenary. It's exciting to see that the techniques have actually worked for this, which is so great. And I want to express my gratitude for that. I've been in the South room, and there's been a lot of interesting discussion and also sharing of experiences. And now we're all going to hear a short resume of what has been discussed in the different groups. We have like just 5 minutes for each group or each, what we call it, North, East, South, West, to present what we talked about, and we'll do it in so that we start with North, then East, then South, and then West. So I'd like to give the word to the representative from North, for Jannica Curve, please. I think Jannica will share her screen.
Okay.
Can you hear me now or not?
Yes.
Yes, but because there were some technical problems. So it is not very well structured actually, and we had just a brief talk about the problems and tasks in each country, and I think that most of the problems were tasks for national leads. So we realized that there are differences between countries within the North region, and in some countries there are good registries and good professionals and strong communities, and in some countries there is a good access to acute stroke treatment, and it is improving in other countries as well, and there are strong stroke societies in some countries. But the problem is that there is we realize that every country has to have their own plan under the guidance of European Stroke Organization, and the role of a national coordinator is important, and there should be a comprehensive structured plan to reach the authorities and involve them. And the problem is that registries are missing in some countries. In some northern countries there are good registries, but the problem is, as we heard before for Denmark as well, that we do not have any numbers about rehabilitation and life after stroke, and this is a task. And also there is important to build up a network with all hospitals and to
I think there's a technical problem. Leslie, could you?
Yeah, I think Janica is in twice, and I think her audio is through another feed, which is now muted. So Janica, can you unmute your other feed, please?
Okay. Can you hear me now?
You can. We're hearing a very lot of banging in the background, though, just to be aware.
Yes, yes, it is. Actually, it's a reconstruction of our hospital. Unfortunately.
Oh,
but
sounded like an MRI.
Can you hear me now? No.
You can. You can continue.
Okay, there is an equal access for primary and secondary prevention in countries. So involvement of health authorities, we recognize that it is important to increase awareness among the political system and to organize stroke units and implement stroke unit certification process. And also there are differences between regions within one country and also stroke units. And there should be resources to implement guidelines in the countries. We should have involvement of media and stakeholders and national stroke plan, which is actually in some countries, and support for collecting stroke indicators and also for stroke audits. In some countries, there are good patient organizations, but in some countries, these are missing. There was as we heard that the Danish experience is an implementation plan in Denmark together with patient organization, Danish Stroke Registry, and involvement of Parliament. I think that this is all from our brief discussion.
Thank you very much, Janica, for this comprehensive overview and very, very clear overview of your discussion. We'll continue immediately with, let me see, this will be next is East, which is, and now I'll give the word to Adam Kobayashi.
Thank you very much, Hannah. I'm trying to upload my slides, but I can't. Oh, I'm trying.
Or share your screen, perhaps.
Yes. Maybe that would be better. Okay. Share screen. Okay. Okay, so thank you very much once again for inviting me to talk about our common what we have just discussed. Well, the tasks of the national lead, well, we briefly discussed the situation, what is in the country. So it is a bit I put together some bits and pieces that I managed to catch out from the discussion. So as for the tasks of the national lead, from the task we had a consensus that the creation of task forces on the national levels for the stroke action plan would be required. Registries are very important, and also there has been a demand for training of stroke physicians. This is something that probably we have already been doing within the ESO-East. As for the challenging tasks, of course, well, there is a lot of diversity in the organization of stroke care. So we have some countries have no access to thrombectomy, as I understood, to endovascular treatments. Some of them are in the process. So, for example, in Ukraine, there has been a big purchase of CT scanners and angio suites, so probably this will initiate more comprehensive endovascular treatment in Ukraine. Everybody complains of access to rehabilitation and speech therapy in patients, in post-stroke patients. Transport between hospitals, between centers is also an issue in some countries. And access to secondary prevention of stroke. So there is a problem with outpatient clinics for post-stroke patients. Of course, there is also an urge to the certification of stroke units. Most of the countries, some of the countries have already this process. And of course, what we also discussed is the creation of national stroke plans for each country. As for the involvement of health authorities, of course, the major problem is the recognition of stroke as a healthcare problem. But in most of the Eastern countries, there is discussion, there is a link of understanding between the societies and the stroke physicians and the authorities, which is good. This is something that also requires to be elaborated on, and we need to work on. Of course, they should help us and to organize stroke centers and stroke units also on the national and the regional level. Probably a task force which would be a sort of an advisory board for the ministry or for the local authorities would be okay. And of course, the major issue is to convince the authorities about the cost effectiveness and of stroke treatments. So probably this is everything that we have discussed. We didn't get to the patient involvement, so I'm sorry about that. But this is probably something which requires more discussion and more internal discussion. Thank you very much.
Thank you very much, Adam, for this very detailed and well presented overview of your discussion. I would like to continue with asking South Georgios to present what happened in this group.
Okay, I'm sharing my screen. Can you see my screen?
Yes. Yes, I can.
Okay. So there were representatives from different parts of Southern Europe. From Greece, there were representatives from the Hellenic Society of Cerebrovascular Disorders, the Hellenic Neurological Societies, and the patient advocacy group, which is the Hellenic Alliance for Stroke. There was also strong representation from Italy, from the Italian Neurological Society, the Italian Stroke Society, and the Italian Stroke Patient Association. From Cyprus, there was a representation from the Cyprus Stroke Association, which is a patient advocacy group. What we have learned is that in Cyprus, there is not available, or they have not organized yet a stroke society of physicians, and I think there is a gap there, and this is something that should be done in order to have not only a patient advocacy group, but also a physician society that is related to stroke. There was a representative from the Maltese Stroke Association, a representative from the Croatian Stroke Society, a representative from the Slovenian Stroke Society and the Slovenian Stroke Support Organization, and from the Serbian Stroke Association. So the easy to accomplish tasks of the national leads or related to the cooperation between physicians and patient advocacy groups. This has already been implemented in many countries like Israel, like Italy, and also in Greece. I forgot Israel in my opening slide. I forgot Nathan Bornstein from the Israeli Stroke Association. I apologize, but I didn't have time to fill in all the names. I apologize for forgetting Nathan. And then there is the challenging task regarding the cooperation between different scientific societies, because we know that stroke is a disorder that is related to many different specialties, internists, neurologists, interventionalists, cardiologists, and this is a task for the national lead to bring all these societies together and make them to cooperate in order to accomplish tasks in favor of the patients. Now, with regard to involvement of the health authorities, we had a very interesting presentation from the Italian group, both from the Italian Stroke Society and the Italian Neurological Society, but also very importantly by the Italian Stroke Advocacy Group. And there are many challenges regarding the red tape. Sometimes the voice of both the patients and the physicians cannot be heard. And reaching government stakeholders, especially in this time of COVID pandemic. And I can tell you that from my personal experience, I'm the coordinator of the 3 recent groups that, or the ones who have been chosen by the Hellenic Ministry of Health to organize stroke and improve stroke care in Greece. And we have not been able to work with the ministry, although we started very fast and very strong during the past 2 months because of the COVID pandemic. And we had many meetings that were canceled because the ministry is not available right now to work on the stroke action plan. And then we have funding restrictions. Stroke unit implementation is a major challenge. COVID-19 pandemic. We have geographical disparities across different countries. In Italy, between the north and the south, the same in Israel. In Greece, we have between the islands and the mainland. Only in Crete, for example, is mechanical thrombectomy available right now. In Greece and many islands, this is not available, and the patients have to be flown in the mainland. And of course, rehabilitation implementation is another major issue. Joining forces between the patient advocacy groups and the scientific societies would help. And Nathan Bornstein gave us some examples from Israel. Registered data was requested both by Italian and Greek health authorities to capture the reality in each separate country and to implement the next steps based on actual data. And of course, perseverance in communicating success is another important factor that may assist to involve more the health authorities. We didn't have real time to discuss challenges and new opportunities for patient involvement, and I apologize for that, but this was not discussed, so I'm not going to go on this issue right now. And there was a very positive feedback on the declaration. We were very happy to hear from Nathan Bornstein that this was already signed in Israel, and everybody agreed that this would be most helpful in the countries, especially of the South. But then just signing a piece of paper does mean nothing, and we need to implement what we sign, and this is a real challenge. So thank you, and I apologize if I left somebody who has contributed in the discussion, and I'm sorry for these sloppy slides.
Okay. Thank you, George. You've got nothing to be sorry about. So now we've had the feedback from all 4 groups, which is very, very useful. But I think we should have a short discussion, which we all rather we have time for actually for 15 minutes of Q&A. So I give the word to Urs, please.
Anna, did we hear back from the West?
West is missing.
Did I forget the West? Oh, I'm so sorry. That's because I don't care about the West. So sorry. I give the word to sorry. I give the word to Anna Fonseca. Really sorry.
So 15 people participated in this group. Regarding our summary of the tasks of national leads, we defined as easy to accomplish tasks, mapping the current situation, establishing the background, and knowing and doing a stakeholder analysis. Challenging tasks, we talked about the importance of having a broad committee working with the leader, involving different professionals, patients, and relatives. Also, the importance of having local government involved in this process and stakeholders, and trying to establish measurable and feasible goals. That was also a very important point. Regarding the involvement of health authorities, we talked about the importance of involving local government and stakeholders, and what would help in order to engage them, asking them to be part of the network directly and trying to have a more inclusive attitude. So we did spend more time speaking about patient involvement than the other groups, I think. So we find as possible challenges, trying to conciliate different interests in the stroke pathway, because patients tend to focus more on rehabilitation, while medics trying to focus more in acute treatment and prevention. Also trying to establish an united front and how to overcome division, because we tend to think in different sides, patients and medics, and we have to work together. And sometimes there are cultural issues that may prevent us from working together. It's also important to know who is the average patient. Are these patients that are participating in these groups or societies truly representative of the patients group? And we also talked about the problem of having low literacy in some groups, and that may prevent patients from really participating into the stroke action plan. Regarding new opportunities, there's opportunity to cooperate, that's undoubtable, to be in the same site, and also a good opportunity to try to build focus groups. I really didn't get to the last slide regarding to the collaboration.
Thank you very much. This was very, very useful. I'm glad that we got the West included into Europe. We now have time for a Q&A session, so I give the word to Urs, please.
Yes, currently there are only encouraging comments, but please use the chat function again to ask questions or to write your comments so that we can discuss it. In the meantime, I think I would like to ask you, Hani, a question. So what do you think now, how the task between the implementation committee and the national coordinator should be divided, and how can we support each other in a constructive manner?
I think that it's, I think first of all, that the feedback from the 4 regions have been surprisingly similar, which is really, really useful because it makes it so much stronger. I think that the role of the steering committee is to identify a small number of crucial issues to focus on, whereas it's the national coordinators who will actually be doing the real work. It will be the national coordinators with the support of the steering committee who will work on getting national stroke plans, etc. So I think that it's more a question of collaboration and supporting than it's about sharing the work. And I think it's very, very important, what I also saw I think all 4 groups said that we need to take the differences between countries, both in healthcare systems and in culture, into account. And only the national coordinators will know what things are like in their country. Does that answer your question?
Absolutely. Currently, there are no further questions so far, but so let me continue with asking you questions. What should we do in countries where we have different societies, different stakeholders? Sometimes it's difficult to find one single national coordinator for a country. How should we address this issue?
Who are you asking, me or?
Yes.
Yes. I think it's important that we align with the individual countries. And some countries will have more than one society, and then we will have to find a solution where both societies are involved. Because this is not about making everybody the same in Europe. One size does not fit all. What is our job is to set the stage for all good people to come and work for the common cause. So this is practical problems which we need to work with. So it's not like we should flip a coin if it should be this or that society that should participate. We need to find individual solutions where that is needed.
Right. There is now a question coming in from Markus Wagner from Germany. He's quoting, national coordinators should look out for sponsoring. Could you give some examples how should be involved on a national basis? So sponsoring on a national basis.
I'm not sure what that means.
Markus, may I kindly ask you to be a little bit more precise?
Because I think sponsoring, that sounds like getting money or something like that, but I'm not sure if I understand correctly.
Yeah, maybe I can ask, I'm relating to one of the slides of Francesca, and this is mentioned there that the coordinators should look for sponsoring. And as I know, industry is not involved so far, and I think that's a good thing that industry is not involved. So maybe you can just comment on that, because I didn't know who could sponsor this national activities.
To tell you the truth, I do not recall that detail on Francesca's slide. Maybe she would be able to respond to this.
Francesca Romana.
I'm sorry, I didn't hear it. Could you repeat it, because I had a bad connection just while you were, I was reconnecting while you were talking. I'm sorry, Urs, can you repeat the question?
Yes, it's mainly the question of Markus Wagner. You were mentioning on one of your slides that you need sponsoring for national coordinators, and Markus wanted to know what you meant with the sponsoring.
With sponsoring, the sponsor, of course, I didn't meant any private sponsor, but I meant the person that put the institution that somehow commit to the cause and take the cause along the way. That's what I meant. I didn't meant anything different from this. So the sponsor is the institution, the group, the working group, the committee that is committed to the cause of the action plan and work in order to. That's what I meant.
Okay, thank you so much. Any other questions, comments? Please use the chat function.
But actually, yeah, Urs, because I'm sorry, but I don't know if I understood even correctly, because the line is very bad. I don't know why in the last 5 minutes something.
Okay, let's move on then. There is one comment from Alain. Alain, would you please ask your question yourself, please?
Hannah, just a quick question. Is there a way that we can introduce the stroke support organisations to the national scientific societies in each country? Because I don't know if they know each other, or if at the moment it's just a list of people. I'm thinking about how do we hook, because we've done this mapping exercise, how can we hook up the societies together so over to you.
The plan is that this will happen in the next step in the communication sent from, well, this is a little bit ahead of everything, but now just answer the question. One of the next steps that we're going to do is that we're going to kindly ask the national coordinators, including them, as well as the stroke support organizations in their countries, to contact health governmental officers, and then we're going to ask them to do it together, basically. And as you know, we're making this document which we will send to them to support the course and describe what we're actually going to do. But so that's the plan. We're going to ask them to do it together. But perhaps more is needed. But I have just simply assumed that everybody knew each other. But you're probably right. That's possible. I don't know. We'll have to discuss that, Aline.
I think that's a very important point, because I think we should also have the national coordinators and societies more visible, also on our website, everywhere, that we know who is taking the lead in which country, that people can connect to each other. And we have to think whether we should have a member area on our platform where people can connect, can chat, can load up documents which they used in their countries. There is a question or a comment from Susanna Dovina from Slovakia. Susanna, are you here? Could you please just ask your question?
Yes, I am here. The question was if there is any possibility from ESO to ask the government to prepare national stroke plans, because it is something I think has a higher value than I will speak with the government that we should prepare it. It should be organized by the Europe or by the ESO.
Can I answer to that? Yes, Susanna, I completely agree with that. And that is certainly also the plan, because the next step will be that we will, together with the individual countries, we're preparing a contact with exactly that purpose to the government. So the answer is clearly yes, and I completely agree.
It would be nice. I think that's helpful.
That's a very important comment. Are there any further questions or inputs if what could be used? There is one coming in from Aleš Tomek. It could help if ESO SAP committee prepares letter with local SAP task forces. Hanne, would you like to comment?
Yes, we're working on that.
Okay. Brief and clear answer. Any further questions, comments, please use the chat function. I think it's the easiest way how we can communicate. No further messages. So Hanne, would you like to take over?
Yes, and thank you very much, Urs, and it also fits with the time. I would like to have my my slides for about wrap up and next steps. Next slide, please. So we've had an overview. We've been discussing basically a number of issues in relation to how to communicate with health authorities, and had both feedback on that from the 4 groups, North, East, West, and South, but also from Valeria Casa's presentation. And from what I heard, I was in the South group, actually the conclusion from Valeria was exactly the same as the words that came from Nathan Bornstein later. And that was that, to put it in a nasty way, politicians do not listen to physicians because they, for many both good and bad reasons, but politicians listen more to what patients say. But as a matter of fact, from our point of view, that does not really matter, because as long as we agree, and so far we do, who cares to whom they listen? We need to collaborate. And that is what we're going to work on. So we had reports of successes based on 3 very different or rather different ways of improving stroke care, also showing that there's not just one way of doing it, which is also the principle of the SAP-E. We've been discussing the task of national coordinators, and these national coordinators will be absolutely crucial for the success of SAP-E, because those are the ones who can make things happen in their own countries. The task of us in the steering committee is to assist, support, both primarily by doing this, making this into a European effort, which can then be carried by the individual coordinators into their country. But it's only the national coordinator who will know what happens in their own country and who can understand what works in their setup. Patient involvement is crucial, and not only to get the attention of the politician, but also because, how to put it, in Danish, we don't just say patients for this, we call it users, because that's basically what they are. They use our services, and nobody would, selling cars would not ask those who buy the cars if what they get is what they want. So I think we need to also look at this very, very practical way, that it's only the patient who will know if what we do feels like it's the right help, and that's why we need to discuss it. It's not that we should think that patients are doctors or doctors are patients, but we have to provide our different input to ensure that what we do is right. The feedback from the regional breakout session was surprisingly similar, which will make it far more easy for us to include. And I will at this point kindly ask all the leads who have the presentations to send them to Katrin Pokrand, because otherwise we will not have access to these documents. Do not take time to make them look nicer, because we're just looking for the contents. Next slide, please. For the more practical part of this, I would kindly ask the national coordinators to confirm who will be the national coordinator for the country. This should be the one identified by the scientific society, but should work closely with the person identified by the stroke support organizations. The national, in some countries, there are more than one scientific society, or some regions have their own society covering entirely that region. It is our politics that we want to make things work with the individual countries. So if this does not fit with you to have one national coordinator, we will talk about how we make this work so that it's also practical from our end. And what the national coordinators should do first is to initiate a stakeholder analysis to find out whom they should work with and be prepared for the next steps. We will talk again at the next rollout meetings, which will be on the 8th of December and the 19th of January. For the 8th of December, we will focus on the declaration, and for the process indicators, the key performance indicators, which we will suggest and want to finalize with you. Secondly, we will start working on getting you in touch with your ministries of health. Please remember to register. Well, I just said that the draft declaration and the key performance indicators will be sent out. Also, please visit our homepage. Also, please visit the SAP-E virtual stand, which I think is still there. And the recording of this meeting will also be uploaded to the homepage. If you have any questions, comments, please contact us by the ESO info, ESO Stroke, and we will answer to these questions. Next slide. I can't recall. I don't think there's a next slide. So so this was the wrap up and the next steps. I'm so grateful for having you aboard. I'm looking forward to the next meeting. Any feedback, any comments, please get back to us. Thank you very much for today. And I think we actually kept time. Any comments from Francesca or Aline at this stage? No. Then thank you very much, and we can close.